everyone. Good evening. We are so sorry for the delay. We had some technical difficulties, but we are very excited to have you here tonight. Hopefully everybody else got into the webinar okay. Thank you again for joining us today for today's webinar on Pompe disease. My name is Kayla White, and I'm a community education specialist at MDA. We're thrilled to have you join us today for this webinar. This learning series is part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and will be posting it to the website for on-demand viewing at a later date. Please know that all phone lines have been muted, but we will have a question and answer session at the end of the webinar. You can use the chat feature to type in your questions and feel free to send them in as you think of them. They'll be addressed after the presentation. I would also like to thank our webinar supporter, Amicus Therapeutics. We would not be able to provide community education webinars like this if not for their generous support, and we are very thankful and appreciative. For over 70 years, MDA has led the way in accelerating research, advancing care, and advocating for the support of our families. MDA's mission is to empower people living with muscular dystrophy, ALS, and related neuromuscular diseases to live longer, more independent lives. Our mission comes to life through these four pillars of care, champion, catalyst, and community. If you haven't done so already, we invite you to join the MDA community by registering with us. I would now like to introduce today's guest, Dr. Tahseen Mozaffar. Dr. Mozaffar is a professor of neurology, orthopedic surgery, and pathology and laboratory medicine at the University of California, Irvine. He is the director of the UC Irvine-MDA ALS and Neuromuscular Center and the director of the Division of Neuromuscular Diseases. We are so excited to have you here today, Dr. Mozaffar. Thank you so much for sticking with us through the technology problems. I'll now turn the time over to you.
Thank you, Kayla. And as what was ironic was that we actually did a dry run and we didn't have any issues with it. So hopefully I'll be able to actually share my PowerPoint. Let's see if that technology doesn't fail us. Can you guys see this?
Yes.
Okay. All right. Thank you, Kayla. And it's my real pleasure to talk about a disease that is very close and dear to me. We are lucky that we have a large Pompe clinic that we run 5 times a year and have taken care of a number of patients. And some of the insights that I'm going to share have come from my participation in the care of these Pompe patients and some of the clinical trials. So as Kayla mentioned, I run the neuromuscular program here at Irvine. I've been here for 23 years, and we have a large muscular dystrophy association clinic that also takes care of a lot of the Pompe patients. As part of my interest in rare and ultra-rare diseases, I advise a number of pharmaceutical companies on trial design, but also advise them on new opportunities in muscle and have research fundings through a number of sources, including the NIH and the Muscular Dystrophy Association. My hope is that I can educate you a little about disease pattern, the pathogenesis of the disease, and what are the current diagnostic tools and algorithms for Pompe disease. I want to talk briefly about the impact of Pompe disease and quality of life and the unmet needs. And I've been thinking a lot about what are the current unmet needs in clinical and research care of patients, and I'll talk about some of those issues. I do want to outline the progressive nature of the disease and why it's important to do early initiation of treatment and what are the current treatment options and what's on the horizon, which is equally important. So Pompe is a relatively new disease. It was described for the first time in 1930 by a Dutch physician whose name was Johannes Pompe. So it's an eponymous disease. It's named after a man who practiced in the Netherlands and was the first one to describe Pompe in the sense that he was doing an autopsy on a 7-month-old girl who died of pneumonia, and he described the characteristic enlargement of the heart, which is well known in the infantile form of the disease, and then was able to show under the microscope that there was glycogen deposition in these muscles. So the disease was named after him. Unfortunately, he met a premature end. He was working for the Dutch resistance during the Second World War and was found to carry a transmitter in his office and was executed by the Nazis during the war. So the disease is known as glycogen storage disease type 2 or GST2. In the neurology circles, it's also known as acid maltase disease, and it still persists as a terminology. But there was a decision made about 10, 15 years ago that we should, for sake of uniformity, call it Pompe disease. We know it's a lysosomal storage disorder. We know it's a deficiency of a critical enzyme in the pathway that it leads to glycogen synthesis. So this is the acid alpha glucosidase enzyme, which mainly lives in the lysosome and requires an acidic environment for it to work, which is normally present in the lysosomes. It's an autosomal recessive disease, which means it can skip generation, and you need to have two separate mutations to have the disease, one coming from the father, one coming from the mother. And to date, there have been over 300 mutations that have been described in this enzyme that are responsible for Pompe disease. But there is a broad spectrum of illness. We know that there are certain ethnic and racial groups that are much more susceptible to Pompe, especially African Americans and Southeast Asian individuals. The findings that suggest that somebody may have Pompe disease is weakness of the limbs, predominantly in the legs, but also in the upper extremity. And this is what we call in our technical jargon as a limb girdle pattern of muscle weakness, where the hip extensors or the gluteal muscles get affected first. Then you have weakness of the hip adductors, the muscles that bring your legs in, are affected. And then ultimately the hip flexors as well as hip extensors get affected as well. Now, the EMG, which is the electrical testing, is abnormal and does have a characteristic pattern. But one of the clues that we see on clinical exam is a drop in the pulmonary or the lung capacity going from sitting to supine. And that, in a lot of cases, gives us the earliest clues that we are dealing with Pompe disease. And I've diagnosed many patients purely on the basis of this abnormality. Now, if you do happen to do a muscle biopsy, which is becoming very rare in clinical care of Pompe disease, you will see that normal muscle fibers, which I point out here, are okay, but there are muscle fibers that are completely replaced by these holes, which are glycogen filled. So normal muscle fiber, normal muscle fiber, normal muscle fiber, somewhat normal muscle fiber in a muscle fiber that's almost completely replaced by glycogen. And this is a specific stain for glycogen, and you can see the increased purple staining is excess amount of glycogen in these muscles. Now, once the disease gets advanced staged, then you see many more muscle fibers get replaced by glycogen. And within the muscle fiber, there is increased activity of a stain called acid phosphatase. Acid phosphatase is a lysosomal stain, and it sort of suggests that there is abnormal lysosomal activity. The lysosomes, which is one of the organs within the cell, is swollen and abnormal. And that's where most of the glycogen deposition happens. Now, if you take the muscle to an electron microscopy or very high definition imaging, you can see that there is definite glycogen storage. All of this purple stuff is glycogen in the muscle fiber. But when you look under the electron microscopy, the lysosomes are expanded, they're swollen, and they're full of glycogen. And ultimately, they will burst out of the lysosome and into the sarcoplasm or the cytoplasm of the tissue. And ultimately, they will create these autophagic vacuoles. And this also works as a space occupying problem. So they interfere with the normal functioning of the muscle. This is a normal muscle. You can see these striation, but then this crud or this material is insoluble. It sits there and it interferes mechanically with the normal functioning of the muscle fiber. And the muscle fiber ultimately becomes abnormal. So this is the different stages of the disease. Really early on in the disease, you still have a very functional muscle, the very few glycogen-filled lysosomes. There is mild or very early in abnormality of the muscle, but this may not be clinically detectable, and the patient may go on to live a relatively normal life. Now, as the glycogen accumulation starts getting bigger and bigger, it becomes visible, especially within the lysosomes. There is progressive dysfunction of the muscle. So the muscle becomes progressively weak, and there are functional impairment, inability to exercise, inability to go long distance. Ultimately, if this is not treated, or sometimes despite our best effort at treating, there is breakdown of glycogen out of the lysosome and into the cytoplasm. So it no longer has the acidic environment. It's freely interspersed between muscle fiber. And this is what we would call an irreversible stage of muscle damage, whereas these two stages before that are still very reversible, very treatable. And our goal in treatment generally is to prevent the muscle from going from this stage to this stage so it doesn't become irreversible. Okay. And that's why early diagnosis is important and early institution of treatment is going to be important. All right. What happens eventually mechanistically is that you have a defect in the glycogen synthesis pathway and you have excessive amount of glycogen that is left here. And this will then will go through the normal mechanisms of breakdown. But because your normal mechanisms of muscle breakdown are overwhelmed because of excessive amount of glycogen, they became part of the cell and there's excessive amount. So this glycogen buildup leads to energy deficits. It creates signaling abnormalities within the cell. And because the body cannot handle this excess amount of glycogen, it causes autophagic defects. Autophagy is the normal process by which cell takes care of excessive amounts of protein and debris, and these will become insoluble and become aggregates. So if you look at this panel on the right, this is muscle culture. So these are muscle fibers which are relatively early in Pompe disease, and all of this pink material are autophagic materials, but it's very small amount. But if you look at the advanced stages of the muscle, the entire muscle is now taken over by these autophagic material, autophagic vacuoles. And this is really bad. This is where the muscle dysfunction happens. But this in some ways is also irreversible to some extent. So pathophysiologically, there is a progressive expansion of glycogen-filled lysosomes in multiple muscle tissues, especially heart and diaphragm and the skeletal muscle. The skeletal muscle and the heart muscles are most affected. Most cardiac muscle is much more affected in pediatric or infantile cases. Skeletal and diaphragmatic muscles are predominantly the muscle affected in late onset or adult onset disease. We know that enzyme replacement therapy is quite successful in reversing the cardiac muscle involvement. So infantile Pompe disease really works very well. It doesn't work as well in skeletal muscle abnormalities, especially in the late onset. And certain muscles are much more amenable to treatment, others are not. For instance, the diaphragm muscle does respond to treatment with enzyme replacement therapy, but quadriceps or triceps may not be as responsive to it. And then in 1970, Professor Engel from Mayo Clinic actually demonstrated the abnormal autophagy. And this abnormal autophagic buildup, because your autophagic mechanisms are not working, ultimately causes loss of contractility, the muscle mass. It affects the trafficking and delivery of the recombinant enzyme. The drug is diverted away from its intended target in the muscle and lysosomes, and it instead ends up in autophagic area, which is the sink for the recombinant enzyme. The incidence traditionally has been thought to be 1 in 40,000, and this was work done in the 70s and 80s in New York City as well as in the Netherlands. So we used to think that the incidence is 1 in 40,000 for overall for Pompe disease. For infantile disease, which is less common than late onset disease, it was 1 in 138,000, and the late onset disease was 1 in 57,000. Disease. As I mentioned, certain populations are at higher risk. So African Americans, the Taiwanese Chinese population, as well as the Dutch population seems to have higher incidence of Pompe disease. Now, in 67 as through 1970, there were a bunch of seminal papers published by Dr. Engel at the Mayo Clinic who described Pompe disease in adults. As I mentioned, in the neurology circle, it's known as acid maltase deficiency, but it really is what we're talking about is Pompe disease. Till then, we did not appreciate that Pompe disease also happened in adults or late childhood. It was mainly thought to be an infantile disease, and this, for the first time, established the presence of in adult onset Pompe disease. That it is a disease that can have many symptoms, and it's a disease that have many different versions of manifestation. So in majority of the patients, it presents with a limb girdle muscle weakness. So primarily the hip girdle or the shoulder girdle muscles, but you have less common features of the disease such as ptosis, bulbar weakness, which is the weakness of the throat and the swallowing muscles, as well as scapular winging or jutting out of the scapula in patients. And I find it very helpful if I see that. Respiratory insufficiency or at least evidence for diaphragm not working is very common in this disease. I would say it probably occurs in majority of the patients, and I find it really disturbing in terms of establishing the diagnosis if the diaphragm is not affected. Late in the disease, you can get neck drop, but also a bent spine. So a lot of the patients start stooping forward or camptocormia, and that becomes very common. But even without the presence of scapular winging, I find the weakness of the infraspinatus muscles, which are your external rotators of the upper extremity, to be a very useful clue to suspect that somebody has Pompe disease. It mimics a number of other muscle diseases. So it looks like limb girdle muscular dystrophy, the main distinguishing feature being the respiratory insufficiency, but it can look like polymyositis, and it's not uncommon that patients with Pompe disease, especially as they're being worked up or as they're trying to get diagnosed, may be mistaken for or misdiagnosed for multiple different diseases that look similar. And in fact, we are currently characterizing how common is this misdiagnosis, and because ultimately it causes a delay in the ultimate diagnosis of Pompe disease, but also equally importantly, these patients may be treated with unnecessary medication. So for instance, if they're diagnosed with polymyositis, they may be treated with steroids, they may be given immunosuppressive medication that potentially may do more harm to them than good. So I'm going to illustrate this with a example of one of my patients who is a bright young man. He's now in his 40s, but he presented to me for the first time when he was 23 years old, and he was trying to do a master's in muscle disorders. He had known his diagnosis. He was a very motivated young man, and he wanted to work towards finding a cure or a cause for the disease. He had a 2-year history of progressive proximal weakness in the hip girdle, and now had started to develop some shoulder girdle muscles, denied any pain. He had noticed problems with shortness of breath, especially on exertion, and that was a relatively new symptom. Denied any skin rash and denied any family history at that time, which is not unusual because remember, it's a recessive disease. His examination showed predominantly upper and lower extremity weakness, but primarily in the hip and shoulder girdle muscles. So the muscles around the scapula, muscles around the hip were primarily affected. There was no skin rash. His muscle enzymes were elevated at 1200, so we knew that we were dealing with a muscle disease. And then we did a lung capacity testing, which is routinely done in our clinic. And he was normal when he was sitting up. His lung capacity was 87%. But look what happened when he laid down. The moment he went supine, there was a 24% drop in his lung capacity going from sitting to supine. And that is abnormal. Anything higher than 10% would suggest that we are dealing with a diaphragmatic insufficiency or weakness. and he clearly had the evidence for diaphragmatic. His EMG did show primary muscle disease. He had a lot of irritability, so we saw a lot of fibrillations and myotonic discharges. And especially if you see that in the muscles around the spine, that is almost diagnostic of Pompe disease. That's what we teach our fellows. That's what we teach our residents and the neurologists, that if you see myotonic discharges, which sound like revving of a motorcycle or a dive bomber, although nobody has heard a dive bomber recently, that is almost classic of Pompe disease. So at this point, we had a very strong suspicion we were dealing with Pompe disease. We needed to prove it so we can start him on treatment. So he underwent a quadriceps muscle biopsy in the leg. And unfortunately, that biopsy did not show anything specific. It did not show inflammation. It did not show vacuoles. It did not show any glycogen deposition. And this, unfortunately, can happen. The disease can be patchy. And despite your best effort, you pick a muscle that you think is abnormal, and your muscle biopsy may come back as normal. So that's the frustrating part of using muscle biopsy as a diagnostic tool. So we then were allowed this opportunity to send off his blood for the estimation of the enzyme, the GA enzyme, and it came out in a deficiency range. It was very low. It was 1.5 picomole, which where the normal is usually above 4 picomole. And then we used the same muscle tissue that we already had, and we sent it off for enzyme assay. Whereas the normal enzyme levels are usually between 30 to 40, or starts from 30 to 40% and higher, his muscle enzymes were only at about 15%. Obviously, we wanted to make sure that we knew everything about his genetics, and we were able to document and demonstrate that he had two separate mutations, one coming from the father side of the family and the other coming from the mother side of the family. And that completely established or fully established his diagnosis of Pompe disease. Now, I want to highlight this Caucasian mutation. So it turns out that there is a particular mutation, this splice site mutation, that is exceedingly common in Caucasian patients with Pompe and may account for about 90% of patients in a clinic, because depending on the distribution of Caucasian versus non-Caucasian patients. This tends to be a milder mutation, but it's almost always combined with a more aggressive mutation to cause symptomatic Pompe disease. So this gentleman clearly had that as an example. Now, over the years, he had decline in his lung capacity, but I really want to show you the differential drop in his lung capacity. So this is his lung capacity at 90% when he's sitting up, but drops to 80% or lower when he's laying down. And that is a very classical pattern in Pompe disease where you have greater than 10% drop. Now, this is another patient with Pompe where I'm showing that you can actually stabilize these abnormalities over a prolonged period of time. So this is data from 2007 all the way to 2015. And you can see that the pulmonary function numbers, the forced vital capacity, both in erect and supine posture, as well as the diaphragmatic pressure, which is the inspiratory force, has remained very stable. If anything's improving over time. And then ultimately there may be a slight decline, but you can keep it stable for more than 10 years. And this was only possible after treatment was introduced in 2007. Now, the weakness does become very prominent, and that is the most prominent complaint that patients will describe, that they have difficulty with muscle strength, but they also talk about walking difficulty or ambulation difficulty. Proximal muscles of the upper extremity are also involved in about 1/3 of the cases. And then trunk weakness resulting in stooping posture occurs in about 27%. Ability to exercise, shortness of breath after exercise, all of those become quite prominent in patients with this disease. And there is a gradual and overall reduction in leisure activities, both inside as well as outside. And there is a increasing dysfunctionality with mobility, both indoors and outdoors. They have difficulty with household chores and being able to do activities of daily living. So it is a disabling muscle weakness. It causes significant disability, both from a point of view of muscle strength, but also the reduced capacity from a lung function point of view to be able to do exercise or activity. It can present with just isolated elevation of muscle enzymes. That occurs in about 12%. Majority of the time, it is a combination of high muscle enzyme, generalized limb girdle pattern muscle weakness, and problems with ventilation or breathing. But it can present just with leg weakness or just with shoulder weakness in combination with the high CK levels, or it may present in a very small minority of patients just with problems with breathing and ventilation. Unfortunately, we still have significant delays in diagnosis, and this unfortunately leads to some irreversible disease in some muscles. It's been looked at in various studies, and I will present some data. But also, by the time the patient presents, because of the increasing muscle weakness and irreversibility, they get significant morbidity from the disease. And quality of life is overall impacted. So this is a study by Dr. Krishnani's group. This is data from the Pompe registry. And generally there is a delay in diagnosis. So this is patients, especially pediatric patients, where the delay fortunately was not that bad because of the cardiac involvement. But in adult patients or late onset patients, you can see some of the patients had delays up to 12 years before a final diagnosis of Pompe disease was made. And that you can understand why that would be devastating, because you have 12 years of uncontested muscle pathology and results in irreversible muscle weakness. And as I talked about, the quality of life is affected pretty much in all domains. So every single domain, whereas the quality of life should be out here, the quality of life is reduced. And these are the different domains within the quality of life that are affected, whether it's body function, whether it's psychological function, etc. It really does play havoc with the quality of life of the patient. And we know that compared to age-matched individuals, there is reduced life expectancy, and there is early mortality or increased mortality, especially in patients who are wheelchair restricted or wheelchair confined. So this disease does cause increased chances of dying from the disease. So how do you establish a diagnosis? Back in 2009, a number of us who were considered experts on the disease were essentially locked up in a room in Dallas airport, and we had to come up with a algorithm by which we can train the physicians, neurologists, other specialties to diagnose. And there were two pathways that we took. One was patients who presented with limb girdle muscle weakness, or patients who present with shortness of breath and muscle weakness. And ultimately, what we talked about was that in diagnosis of Pompe can be easily established by means of the sending off their blood for GA enzyme activity. And if there is a deficiency range enzyme activity or low enzyme activity, it should be confirmed with a second line of test, but that is quite sensitive for picking up Pompe disease. One caveat that we talked about in that paper was that nobody should ever be diagnosed purely on the basis of the enzyme assay on the blood. It should be confirmed with either a genetic testing or a muscle biopsy or a muscle estimation of enzyme, because you can have false positives. So there are patients, especially of Asian origins, who have pseudodeficiency. They may have low enzyme on testing, but they actually don't have Pompe disease. So that was the reason for that that caution that we prescribed at that time. However, that paradigm, at least in the US, has changed because of free availability or increased availability of free genetic testing. So this was a study out of Emory Genetics Laboratory in Atlanta, that I was lucky to participate in. There were 3 neurologists from the US that were part of the study, Matt Wickland, myself, and Matt Harms. And we advised the MDA that sponsored this study. So essentially what we did was anyone who was in our clinic who did not have a definitive diagnosis of muscular dystrophy or muscle disease, but did have muscle weakness on exam or had high CK levels on enzyme, we sent off their blood test to Emory Genetics Laboratory in Atlanta for free, and they were able to then test it for different genetic mutation. And you can see that we were able to solve a number of these cases. Some of the more common muscular dystrophies very prominently featured. So limb-girdle 2B, limb-girdle 2A, which we know are much more common, were again found to be much more common in these undiagnosed cases. But look at GAA. We found 23 new cases of Pompe disease in these patients tested. There were over 4,500 patients that were tested as part of this effort. And then there was another 20 patients with GNE, which is incredibly rare, ultra rare muscle disease, and that we were also able to find. So this leads me to sort of conclude that Pompe disease is one in the top 10 category for limb-girdle muscular dystrophy, and the more you look for it, the more you find it in that sense. And within the patients who were ultimately diagnosed with Pompe disease, you can see that that Caucasian mutation actually featured quite prominently. So a majority of these patients, I think there were at least 10 patients who had the Caucasian mutation. We separately did a study starting in 2015. We called it the Ipanema Study. And what we did was we collected a group of 13 academic neuromuscular sites that had large volume practices. We knew that they saw a lot of muscle diseases. And we asked them to start screening these patients, any patient that came in through the door with either muscle weakness, especially in the proximal muscles, or they had high CK levels, or they had neck flexor weakness. We asked them to send the enzyme off to testing, and we found out that 1% of these 900 patients were actually had Pompe disease. We proved it by means of genetic testing, but another 1% of these patients also were found to have pseudodeficiency, where they have low levels of the enzyme, but they don't actually have the disease on that. This is Marie Wenzel, who was my coordinator and project manager, did a wonderful job of managing these 13 sites. And because the name had Ipanema, I had to take one for the team and actually visit Ipanema Beach, so I could show to the world that Ipanema does exist. So the challenge that we face now is that especially infantile onset Pompe disease is fatal. If you don't treat it, these kids will die within a year or 2 years of their birth. So how do we start diagnosing them early? How do we catch them early before they develop significant cardiac or heart disease? How do we reduce these diagnostic delays? Because we showed you the evidence that on an average, it's taking about 12 years to diagnose Pompe disease. And it's primarily because of lack of awareness. A lot of neurologists, a lot of other physicians are not thinking of Pompe disease, and they're not testing for Pompe disease. Pompe disease is a treatable condition, and any delay in diagnosis and any delay in treatment is not acceptable because it results in reversible disease and you're not managing. So how do we diagnose early, and how do we treat early? So independently, there was an effort to include Pompe disease in the newborn screening. So as you know, there are states in the US that test for a variety of genetically inherited diseases at birth. And one of the main criteria is that there has to be a treatment that is effective for these diseases, and that's why you want to catch them early. So to get on the panel for testing, the disease has to be treatable, and Pompe was added to this list in 2016. And again, the rationale for including it in the newborn screening panel nationally as well as in individual state was that it's a treatable condition. There is an effective treatment for reversing and preventing cardiomyopathy, and it also works on respiratory insufficiency. The prevalence is generally higher than estimated, and early treatment is most effective before the muscle turns irreversible. There are also pre-symptomatic patients that can be identified, that can be monitored, that can be followed over time. And by picking up these patients early, we'll gain very valuable knowledge on how the disease progresses and whether carriers are affected in any way or not. Now, there is a counter agreement, and I have to say that I was one of the people who was not in favor of doing newborn screening. And the reason primarily for me was that 3/4 of the patient that we're going to pick up at birth are going to have the mutation that predicts a late onset disease. So they are not going to get the disease for 15 to 20 years. And we're not going to be doing anything other than causing anxiety. Now, I completely agree that in 25% of the cases, which are infantile onset, where cardiomyopathy or heart involvement is very important, early detection will cause early intervention. And we've now shown that over the years, we have been able to prevent a lot of cardiac involvement on that. There was no clear agreement on how to monitor these subjects, who is going to monitor them. The pediatric neurologists are not enough in numbers to be able to do this throughout the country. Geneticists are great people, but generally they are not experts on testing muscle strength. So how do we pick up disease and how do we monitor? And the fear was that there is going to be unnecessary anxiety that we'll be creating, and these patients will unnecessarily be treated early to a treatment which is lifelong. So I was not in favor of it, and a number of us were not in favor. And then there was a concern that because they're going to be discovered at birth to have a genetic form of disease, they may be discriminated for life insurance and long-term disability. So I'm happy to say that majority of the states in the US are doing either Pompe screening alone, or they're doing both Pompe screening as well as screening for SMA, which is another disease that manifests at childhood and is very treatable. This is data as of August of 2022. And again, there are other states being added. So as you see, some states do both. Some states only do screening for spinal muscular atrophy. And then there are states like South Carolina and Ohio that only test for Pompe disease and not spinal muscular atrophy. Now, this is somewhat dated data. So when the newborn screening data started coming out, we were surprised that the incidence was actually much higher than what was previously thought. Remember, I showed you the data that previously it was thought to have an incidence of 1 in 40,000. In fact, the numbers were much higher in Taiwan as well as in Missouri, which has a mixed population of African Americans and Caucasian, or some of the states like Washington, where there's a large Asian population. Over the years, we now have data from a number of other states, and you can see that if you look at, for instance, I believe this is California, the incidence is definitely higher than what we previously estimated on that. In New York and Missouri, it was somewhere in the range of 1 to 16,000. One of my patients, Ryan, who is a rocket engineer, rocket scientist, he's been very interested in this data and he follows it very religiously. And he's recently showed a meta-analysis of all the data from various published data, as well as from the direct data coming out of the newborn screening. And he has estimated that the actual incidence of Pompe disease is 1 in 18,000, which again is a huge increase in number than the previous estimate of 1 in 40,000. Now, the big problem that it poses for people like me is that suggests that we should be seeing a lot of Pompe patients, or at least late onset Pompe patients, in our muscular dystrophy clinics. data, this number is almost the same number as myotonic dystrophy and facioscapulohumeral muscular dystrophy, which are the two most common adult onset muscular dystrophies in our clinics. But we clearly are not seeing that increased number of Pompe patients in our muscular dystrophy clinic. Which begs the question is, why is that? Is this data faulty? Are these patients who have the mutation really don't have penetration of the disease because the mutation is not penetrant? Or are they being misdiagnosed with other diseases such as Pompe disease, such as polymyositis and other muscular dystrophy, and have not been diagnosed as Pompe disease, and therefore getting delayed in terms of diagnosis or treatment? So there are still questions about newborn screening and what's the optimal monitoring scheme in California. Before even state of California rolled out the newborn screening, I had met with them. I literally had begged them to get us involved so we can measure their muscle strength. Unfortunately, it was never done. So I'm still not clear that they are being seen by qualified people who can actually measure muscle strength. It's obviously they don't have the disease yet. So insurance companies would not be happy about paying for routine checks on them every 6 months or every year. So the question is who's paying for it? What's the burden on the individuals, families? And that the fact that we now have to make them pay for it usually results in patients not wanting to come to the clinic. And then there are questions about what are the best tests to confirm or follow the disease once the disease sets in. And the big question is, when do we start them on treatment? At what point do we say that they have enough symptoms or they have started the disease and therefore we should intervene? It also allows for other strategies to be tested. And I think one strategy that I'm really excited about is this new therapy modality called glycogen substrate reduction. So the idea being that you have a defect, or you're not able to handle glycogen in your body, why not reduce the production of glycogen upfront, which we know is reasonably safe in patients. They don't get harmed from reduced glycogen production. But if this works, this would result in significantly delaying disease onset or even deferring the disease to a much later stage. And I think potentially it could be a very good treatment, but it hasn't been tested out. There will be trials coming down the pipeline where they will probably try this. Right now, they're only trying it in patients who are already on treatment as an adjunct therapy. So if patients were getting enzyme replacement and if you put them on glycogen substrate, is the outcome even better if they have less glycogen to deal with? And as I mentioned, the disconnect between the higher incidence of late onset Pompe disease at newborn screening, but low prevalence of them in our clinics is something that is very curious, and we would love to find out why that is the case. And I will highlight it with this example of a 21-year-old man who's otherwise healthy. 13 months ago, he had for some reason, tested for his blood for muscle enzymes, and he had high muscle enzymes. He was ultimately found to have the genetic mutations for late onset Pompe disease. He has absolutely no symptoms. He underwent a cardiac evaluation. In his heart ultrasound was normal. He had a muscle biopsy at 19 months, and there is some glycogen abnormalities in the muscle. But remember, we don't treat the muscle, we treat the patient. The patient has absolutely no limitation in his ability to perform activities of daily living. He's actually a fairly active guy. And on examination by a neuromuscular neurologist, he has absolutely no muscle weakness. So we've now subjected him to yearly exams. He gets muscle testing, he gets CK levels, but we also do the cardiac evaluation. And then he gets lung function testing. He's had MRIs done, and his MRI burden of the disease is not increasing. So what do we do with somebody like him who has the genetic mutation and really has not manifested the disease? It would not be fair for us to start him or commit him to a lifelong treatment for a disease that really has not fully manifested at this point. And this has now, this dilemma, ethical dilemma, has now resulted in a couple of editorials. So this was an editorial written by my friend Jennifer Kwan, who talked about, I'm fine, I'm just waiting for my disease to declare itself. Another editorial in Wall Street Journal that's talking about patients living in a limbo because they don't have the disease, but they've been diagnosed with the disease. On that. Pompe care requires a multidisciplinary approach. So we usually recommend having a care coordinator, a quarterback, who works with a physician, who works with a genetic counselor, who works with a respiratory therapist. It's a holistic approach to patient care. They have to have their functional status tested as well. And at our clinic, we obviously have a large team that takes care of these patients, including physicians, geneticists. Dr. Virginia Kimonis is our geneticist who co-runs the clinic with me. We have a genetic counselor, we have physical therapists, respiratory therapists, research coordinators, etc. When do you decide to treat somebody? This is an example of a young woman who used to live in France. She was diagnosed with Pompe disease. And in France and Europe, they don't automatically get treated with enzyme replacement. They have to have respiratory function abnormality. This patient relocated to the US. I started taking care of her, and I agreed with the French, and I didn't start her on treatment. And you can see for the first few years, her respiratory function, if anything, got better. But then at some point, she started dropping her respiratory function, and we bit the bullet and we decided to start her on treatment. She unfortunately has relocated to another state, and I don't have follow-up data on her on that. So finally, I'm going to talk about some of the milestones and treatment options in Pompe disease. So the first patient was described in 1932. Dr. Corey at Washington University in St. Louis described the biochemical defect in Pompe in 1954. And then over the years, we've understood the disease, and now there is a treatment that was first approved in 2006. The treatment strategy in Pompe will involve either enzyme replacement, where you are able to supply the missing enzyme delivered to the muscle so it can break down the glycogen. As I mentioned, one strategy would be to reduce the amount of glycogen that's being produced so you can have less burden of disease. If you can improve the autophagy, that would be another strategy. And then gene therapy, where you replace the defective gene either in the liver or in the muscle. So you can have your own resumption of your enzyme activity, enzyme production in the body. So you don't depend on external enzyme delivery are some of the strategies there. But I want to mention these individuals who played a very important role in bringing treatment for Pompe patients. So the Duke group, which is Dr. Chen and Dr. Priya Krishnani, and then the Erasmus group in the Netherlands, led by Dr. Reuser and Dr. Hans van der Ploeg. And then Barry Byrne independently has been working a lot in infantile Pompe disease, especially pioneering the role of gene therapy. And he is at University of Florida, but also one of the main advisors for the Muscular Dystrophy Association. Now, the treatment got approved in 2006, and then that was mainly infantile data, but the late onset data on the effect of treatment came out in 2010 in this paper in New England Journal of Medicine, and it convincingly showed that compared to patients who were getting placebo, patients who were receiving the active drug or the L-glucosidase alpha, otherwise known as Lumozyme, did much better in terms of their change in their overall lung function, as well as the ability to walk 6-minute distance, and a number of other parameters, including muscle testing, enzyme testing, CK levels also improved. The sad part is that despite the initial stabilization of the disease, on an average, the enzyme replacement therapy stops working after about 36 months. The other challenge is that only 1% of the enzyme that we deliver in the bloodstream actually makes it to the target organ, which is the muscle or cardiac tissue. And while it's being transported in the blood at room temperature, the enzyme activity is reduced because the enzyme catalytic site is unprotected in the blood. And by the time it gets to the muscle, it doesn't remain as functional as it was when it was infused. And then some patients, especially in the infantile disease, but also in some adults, there are antibodies that develop to the drug. which creates more drug-related side effects, but also potentially may have reduced the drug to be less effective. And then in patients who are not responding to treatment with late onset Pompe disease, when do we quit and say this treatment is not effective and we stop? And so this is some of the data, and this is data coming out of the Erasmus group in Amsterdam, showing that there is an increasing number of red in different domains, and this red means that the treatment is no longer working. If anything, the patient is getting worse. So we know that the treatment stops working or has less effectiveness, and there is an increased amount of burden of disease that accumulates over time despite treatment with ERT. And there are many examples. We have examples of patients who are worsening despite treating with Lumazyme, and it's time to change strategy and put them on something different, whether it's another treatment or clinical trials is probably the best option at that point. But yet there are also patients who have remained remarkably stable over time and have not really changed in terms of their breathing capacity. So there are many problems with treatment. You have a delivery system problem. There are infusion-related side effects. Very few of it is actually going into the muscle. They do not cross the blood-brain barrier, so there is literally no penetration of the drug into the central nervous system, either the spinal cord or the brain. And then there is an immune reaction that happens to the enzyme, especially in children, because they have never seen the enzyme and the body reacts to it once the moment we start delivering the enzyme to them. Switzerland was the only country that was brave enough to try a disruption. So their point was that if the treatment is not working, why continue the drug? And they used the parameters from the original Lumazyme trial. So if the patient worsened on any of the two parameters showing worsening, they stopped the treatment. Unfortunately, that experiment failed. Patients actually got worse when the treatment was stopped. And despite putting them back on the treatment, there were lasting residual effects. So most providers currently do not stop treatment, even if it's not working. Now, we may talk to the patient about going into clinical trials, which are testing new products or trying newly approved FDA medications. So that again, just to revisit the opportunities, you can make the current enzymes better by adding more mannose phosphate tags or other tags that will allow for better muscle entry. You can look at substrate reduction to reduce the amount of glycogen that's being produced. You can always do gene therapy and replace the defective gene, or you can use things like pharmacological stabilizers or chaperones, so the enzyme, while it's being transported in the blood, is protected, etc. So there have been two studies that have been published over the last 2 years. I was lucky enough to be part of both of them. The first one is COMET, which is looking at a drug called Nexviazyme. This was tried in patients who had never previously been treated. This was done in multiple centers in Europe and in the US, and again showed that compared to Lumazyme, which is the standard of care, there were definite improvements and statistically significant improvement for 6-minute walk test as well as lung capacity. It did not reach the predefined statistical significance, so we cannot say that it's superior to Lumazyme, but in a number of parameters, it was statistically better than Lumazyme. So it appears to be a better drug, but again, we cannot use the word superiority because the predetermined statistical analysis did not confirm the superiority of the drug. This drug was approved by the FDA. It's been available for the last 1 year. A number of our patients have switched to it. The other trial was the PROPEL trial, which was by Amicus. Again, I was part of it as a senior author on the paper. And again, this was comparing glucoside plus miglustat, which is the enzyme stabilizer and oral drug, to Lumazyme. And again, similar to the COMET trial, this showed improvement from Lumazyme in the primary as well as the secondary outcome measure, but again did not meet the predetermined definition of superiority. So again, similar to the COMET situation, we cannot call it superior to Lumazyme, but there are a number of parameters where it was statistically better than Lumizyme. This drug still hasn't been approved by the FDA. All expectation is that approval will happen at the end of September. FDA had indicated that the approval decision will happen by the end of the third quarter, which is fast approaching at this point. And on a number of parameters, again, it looked better than Lumizyme. So this is a short table that compares the two trials, and very similar design. The only difference was Propel was only tried, predominantly tried in patients who were switching from Lumizyme, whereas Comet was naive patients. They never saw the enzyme before. So Comet is approved for both naive and switch patients. At this point, because we don't know what the FDA will decide, we do not know if Propel will only be so the cepagliflozin will only be approved for switch patients or both for switch and naive patients. And then finally, I'm going to talk about gene therapy. So gene therapy the idea here is when we give enzyme replacement, you get these large peaks and then the effect of the treatment wears off by the second week when you treat the patient. The idea would be to give a treatment where you have steady levels of the enzyme because you're producing it inside the body. And the most common vector that we are using is the AAV vector. There were a number of companies that were initially in the business of doing gene therapy. These are the three that actually did it. So Actis was bought out by AskBio, which has been subsequently bought out by Bayer. Spark was bought out by Roche, and Spark treated about 4 patients, and Odentis has treated 6 patients so far, or 5 patients so far, and is still ongoing. The difference between the Odentis approach and the approach by Actis and Spark, they're targeting the liver, whereas Odentis is targeting the skeletal muscle. These other two have not started yet. AvroBio just canceled their program a couple of months ago, and then Sarepta had announced that they were going to have a Pompe trial. They bought a company called Lacerta, but then very recently they undid their business contract with Lacerta. So it's not clear at this point if Sarepta will have a gene therapy trial in Pompe. And this is, again, a figure that I borrowed from Dr. Jordi Diaz-Manera's paper, again, looking at the companies that are actively in the business. And finally, I'm going to stop with this very exciting paper that came out, and this was a talk of the town at the last lysosomal meeting, where a patient with infantile Pompe was treated in the womb. So this was a Pakistani woman who had previous 4 miscarriages. Her previous child had infantile Pompe and was diagnosed late and treated late. And then she was pregnant again and found out that her pregnancy, the fetus had infantile Pompe as well. And a decision was made very bravely to give enzyme replacement to the fetus while the patient was still pregnant. This was really a cutting-edge treatment trial. I think it was done in upstate New York with the help of Dr. Kishnani's advice and the UCSF folks who are the pioneers of treatment during the fetus. So this is, again, comparison. This is the family tree. There were 4 previous miscarriages and 1 affected individual previously. This patient that was the previous sibling had enlarged heart by the time he was born, and the treatment was started but was done late. So they continued to have significant cardiomyopathy. This second sibling was diagnosed in fetus, was treated in fetus, and you can see compared to the other sibling, his heart is actually doing really well. There were no significant drama in terms of treatment. These patients usually mount a very robust immune response because they've never seen GA before. So the patient had to be treated with a variety of immunosuppressive agent, and that made sure that the patient did not develop a robust immune response, and the patient has done well. And then these are some pathological data to suggest that the amount of glycogen, so this is the infantile onset Pompe disease, the placentia is full of glycogen. This is the patient who was treated in utero, in the fetus, and there's no glycogen. Same thing with the blood vessels. Blood vessel is full of glycogen. if you don't treat it, this is the patient who was treated during the fetus and really no glycogen, and the same thing with the placenta in other areas. So it's a really exciting period for patients with Pompe disease, given the recent advances in the newer therapeutic options and the prospect of gene therapy and substrate reduction therapy. The newborn screening program has raised many new questions, but also developed new opportunities to understand the disease progression and to treat the infantile disease early and understand how disease develops in the late onset patient. The incidence of Pompe is much higher than previously estimated, but the neuromuscular clinics clearly are not seeing that many patients. We still don't understand fully what the reason behind it is. Is it a misdiagnosis issue? Is it a reduced penetrance issue? And there's much work that needs to be done to address the anti-GA immunity as well as the immunity to the virus, the AAV virus, that is currently limiting our ability to do gene therapy in majority of the patient. And especially if the patients will need treatment again, we really have to overcome this burden. So I'm going to stop here. I'm happy to respond to any critiques or questions. Thank you once again.
Thank you so much, Dr. Mozaffar, for that information. We are running a little bit late, so we'll limit the questions. But one did come in the chat during your presentation, and somebody asked, is Pompe muscular dystrophy associated with limb-girdle muscular dystrophy?
That's a great question. So till about 3 years ago, we had included Pompe in the classification system for limb-girdle muscular dystrophy, and it was given the title or the designation of limb-girdle dystrophy 2V, 2 as in Victor. About 3 years ago, a panel of experts from the European Neuromuscular Center revisited the classification system and threw out a number of limb-girdle muscular dystrophy from that classification system. And the rationale for that was when you look at muscle biopsy from these different muscular dystrophies that were part of that classification system, they did not have dystrophic changes on the muscle biopsy. So unfortunately, Pompe was, much to my chagrin, was taken out of that classification system. The European neuromuscular experts revisited this in June, but Pompe again was left out. It was not included in that time. So at this point, we can say it looks like limb-girdle muscle weakness, but we can't call it limb-girdle muscular dystrophy.
Gotcha. Thank you so much. I'm sorry that we couldn't get to more questions. And again, I apologize for the technical difficulties, but Dr. Mozaffar, we so appreciate your time, your expertise, and everything that you do for the neuromuscular community. We so appreciate you being here tonight. I would also like to again thank our webinar supporter, Amicus Therapeutics. We are thankful and appreciative for their support as well. If you are new to MDA and are diagnosed with a neuromuscular disease under MDA's umbrella, or are a loved one of someone who is diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. We would love to hear your comments about this webinar. If you have a smartphone, you can open your camera and point it at the QR code on the screen, and a webpage will pop up with a short survey on the webinar. If you don't have a smartphone, that's okay. Once the webinar is over, you'll get an email with the survey link in it as well. If anyone has any questions after this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow up with you. This concludes today's webinar. Dr. Mozaffar, thank you so much again for your time. We so appreciate it, and thank you for sharing that wonderful information with us.
Thank you. Take care.
Thank you all very much for attending, and we hope to see you again very soon.